to organize them by community, not just by medical care provider. Let's get data that enables real change and that you can tell when you're doing a good job or not. I think I would change the language of beneficiaries. You know, we keep talking about Medicare and Medicaid beneficiaries. Well, you know, the Medicare and Medicaid, quote, beneficiaries never get to touch a single greenback from those programs. The beneficiaries are the insurance companies, the health plans, the pharma, you know, all those folks who are making a living on Medicare and Medicaid. So let's start calling the people who we have been calling beneficiaries the owner users, and remind us, or the citizen users, the taxpayer users. I mean, and start recognizing that we really need serious input from those, what we now euphemistically call consumers. We have a care, when I worked at CMS, it was stunning. You changed 2 words in the conditions of participation, and you would have 1,000 emails or phone calls by morning. You could change something that nailed a whole group of patients, and nobody was around to speak up. I mean, AGS occasionally showed up, AARP sometimes, Alzheimer's a little bit, but basically there's no voice for frail elders and their caregivers. You know, we need to be putting a whole lot, I mean, I want there to be an act up for old people, you know, and all of you should join, I think, probably Gray Panthers and OWL and see if we can't get them to be the ones that are proposing such harsh and vigorous stuff that reasonable proposals start looking mainstream. Because right now, reasonable proposals look way out there. So let's start mobilizing the consumer input. And then I think we've got to have serious innovation. The innovations that we're funding right now are at such a superficial level. And sure, they'll do some good. Yeah, it's probably okay to have, you know, concurrent care with hospice, or to allow a little bit of an expansion of the PACE program or something. They're all fine. And they won't get us where we need to be in 10 years. In 10 years, we need to be ready for a huge increase in the number of frail and disabled people. So let's start allowing there to be serious innovation that goes across all those different domains, the social services, the long-term care, and the medical care domains. And let's learn what it is that's going to get us through, because otherwise we're going to learn to walk out.
So let's imagine we have, for the moment, an Office of the Triples and comprehensive care plans. I'd be interested in your thoughts, all the panelists, on whether the quality measures, which are still not completely developed, there's a paucity of long-term care measures, quality of life measures, we know that, or long-term care measures in the home and community-based setting anyway. But should they be the same, you know, across Medicare and Medicaid, the Older Americans Act service providers, or should they remain different systems? Maybe that's a naive question, but while I have your brains here, I wanted to ask.
I'll jump at that. Go ahead.
Yeah. Well, I'm just going to make a plug. I think that the aging and disability networks, by and large, have done a lousy job of measuring the quality of their services. We count things. We count how many number of meals. We count how many units of service, but we don't really look at the quality. The DD directors have done a markedly better job by having the national core indicators available to them since, I think, for 15 years. 1997 it started. I'm proud to say that Nashua is working with the DD directors, and in January we will have a similar core indicator survey tool that will be available to all the states that mirrors the DD system, and it will go down to the community. We will be able to judge area agency to area agency, and it measures things like, is the consumer satisfied with their level of services and their ability to stay in their home? So we're really pleased about that. We're piloting it this fall, and it will be ready for implementation in January. So that's one step. I agree with you, though. There are lots of difficulties, and having served on NQF and felt like I was, you know, a stranger in the woods, I think that one of the hard parts is it's all clinical. Everything is judged on a clinical, and I'm so sick of hearing about readmission to hospital as as the only measure of good HCBS services. There's got to be more than that. much, much more than that, but that's all that they'll accept at this point.
Go ahead, Josh.
Well, I'm less concerned about this point about them being consistent because we don't have any measures to make consistent. So I think the science is way back there, and we need to, in order to develop these measures, we need to collect some data, and then we can see whether the data can be made into measures that actually measure in a reliable and valid fashion. But we're not there yet, and it will cost us money to gather the information that will allow us to develop these measures and to collect the data on a regular, routine basis and report it. Because, frankly, we just don't collect all that data now, especially on home and community-based services, because people, by definition, are living in their own homes, and it's very expensive to gather that information.
I think we need to standardize the measures and make them relevant to the population we're serving. And that you certainly would still need to be measuring some counts, and you'd still need to be measuring some things that are particular to a particular program or approach. But there are two things that are really in the way of coherent measurement, in addition to the costs and practicalities that Josh has raised. One is we need to be able to measure the individual care plan against what the person actually received. Everything we measure right now is a professional standard. My mother at 91 just got in the mail a few months ago her recommendations from Medicare as to her preventive services. It was bizarre. I mean, she was recommended to have a pap smear, a colonoscopy, a mammogram at 91. I mean, I've been spending a whole lot of effort talking her out of these things because they're no longer relevant. But the professional standards are still being applied. So a provider gets dinged if they don't have diabetes managed with a hemoglobin A1C under 7, even if the person involved thinks that's utterly irrelevant and just doesn't want to have to get up at night with glycosuria. I mean, we ought to be able to have a care plan that's individually set and then measure whether the person actually got what they set out to get. It's a whole new technology. And then we must be measuring costs. We've got to be measuring costs in an aggregated sort of way. And yes, maybe public and private costs, and there's a whole lot of challenge about exactly how we're going to do it. But in my arena, the frail elderly, the biggest technical snafu is that we have deliberately turned our eyes away from noticing that costs relate to lifespan. So we have this bizarre economic assumption that no matter what you would have gotten, you would have died at the same time. Well, what if providing very good supportive services makes you live another year? That would wipe out any possible gains. But we are not doing anything in terms of developing the technology to understand the effect of various strategies on lifespan because we can't stand to talk about death. Well, that's going to drive us right into bankruptcy. What matters when you're very old, sick, and frail is how long you're going to live that way. That's what runs up the costs. So we're going to have to get past our polite willingness to turn our eyes away. So I think those two things, individual care plans and how to deal with costs associated with survival, are going to have to be broken down in order to develop measures we can rely on.
Well, I want to thank our panelists. I think they're all courageous people, brilliant people, and it's been an incredible discussion. So please join me in a round of applause. And fill out those evaluation forms if you would. That would be great. I also want to thank my colleagues Lee and Sabia at the National Academy of Social Insurance, without whom their immense help would absolutely, this never would have happened. So please thank them as well. And then for those of you who are coming to the Bob Ball dinner, we look forward to seeing you at 5:30. We'll now take a break until 5:30, and then our reception will begin at that time. Thanks so much.